We can start. Yeah. Good morning to everyone. On behalf of Sun Pharma, Pharmacare division, I would like to extend my warm welcome to all the respected panel and all the delegates who are participating in today's discussion. My name is Mahendra Varman, Deputy General Manager, Pharmacare, who is taking care of Pan-India sales operations of my division. Sun Pharma, in our sincere effort towards the medical education to the highly respectable ENT surgeons, in association with the Association of Surgeons of Sleep Apnea, we bring you IASSA Classroom Webinar Series 3 today with our esteemed speakers. Once again, my greetings to all the participants and special Indian wishes of Vanakkam to Dr. Marina Carrasco of Valencia, Spain. Over to Dr. Kishore of Hyderabad. Before that, I would like to make a small announcement, and I request all the doctors to stay with us even after the session, because Mr. Sahai has got a small announcement and for all the ENTs, from which we are offering from ENT surgeons from Sun Pharma. Over to Dr. Srinivas Kishore. Thank you.
Good morning, everybody. I hope I'm loud and clear.
Yes.
Okay. Am I loud and clear?
Yes.
Very clear, very clear.
So my name is Dr. Srinivas Kishore, and I'm going to be your moderator today, folks. This is the third web series or the webinar, which is an initiative by the Indian Association of Surgeons for Sleep Apnea and Sun Pharma. Thank you very much, Sun Pharma, for a fantastic initiative. Today, we have a power pack program, and the last two, this is in continuation to the last two programs that we've had, wherein we've sort of introduced you to the subject. Now, today, we're going to dig a little deeper into the subject of obstructive sleep apnea. We have three well-known, world-renowned speakers. The speakers are Dr. Vijaya Krishnan, who's going to talk about how to read polysomnography. He's going to go start off very superficially and go deep into how to go about understanding the complex polysomnography. At 10:30, we have Dr. Marina, who's from Valencia, Spain, a world-renowned researcher and scientist in the field of obstructive sleep apnea, who's one of our champions in the surgical management of obstructive sleep apnea with many papers in drug-induced sleep endoscopy. And she's going to talk on the title, How DICE Helps in Choosing the Type of Surgery. I think that's a fantastic topic. Then at 11 o'clock, we have our own Vikas Agarwal from Mumbai, who's going to talk on nitty-gritties of DICE classification. And I think by the end of today, you will all have halos like our gods and goddesses and Buddha if you sit through the webinar. So without further ado, I would like to request Dr. Vijaya Krishnan to proceed with his talk. Thank you.
I request all the participants, other than the speaker, to mute their mic.
Yeah, good morning, dear colleagues and friends and seniors. At the outset, I would like to thank IASSA and Sun Pharma for arranging this wonderful classroom webinar series. Today, we are going to talk on how to read polysomnogram as an ENT surgeon. So we all know obstructive sleep apnea is a common disease of both adult and pediatric age group with myriad of presentation. It is a metabolic syndrome. It not just affects upper airway, and it is affects the entire body. That's what we have to keep remembering. It is a spectrum of disorders. It can be just a primary snorer, it could be a severe OSAS, and the management differs according to the severity and the classification. So before going into PSG, just I will give a idea what we are looking at. Only if you know that, then only you will be able to look at in the report. So here, we all know sleep is a naturally recurring state with a reduced or absent consciousness, with a suspended sensory activity and inactivity of voluntary muscles. It is very important, especially in a pediatric age group, for a normal biological, social, and emotional development. If you make a person not to sleep for more than 3 days, he will become mad. So sleep is such an important thing in our life, especially the REM phase of sleep, which regenerates your entire body and the system, and especially the brain. So sleep is broadly classified into REM stage of sleep and non-REM stage of sleep, which is further classified into 3 stages, N1, N2, and N3, not 4 stages. So I'm not going to go in detail about N1, N2, N3, but just to, if you have an idea about what is alpha wave, beta wave, sleep spindles, you will be able to understand and you know what you have to look in when you are looking in a PhD. So REM sleep is very important to understand because if you find a sleep study with less duration of REM sleep, the patient will definitely have a not a refreshing sleep, and the next day he will be feeling drowsy. And if you are going to operate such a patient with a REM disorder, definitely you will not be able to satisfy the patient for which he has come for. So these are the small things which we may have to look in. We all know that there are more than 100 varieties of sleep disorders, but our aim and idea is to look and diagnose sleep apnea. At the same time, we have to know other sleep disorders so that we'll be able to pick up those patients and refer to proper neurologist or psychiatrist or sleep physician, so that we will not tell the patient, no problem, you can go ahead. So proper diagnosis and referring is also integral part of our practice. So we all know again that the gold standard for diagnosing a sleep disorder is polysomnography, which is an essential tool for understanding sleep, and all complex disorders can be diagnosed with a PSG. So PSG is recording sleep, but we are recording many channels. That is what polysomnogram. William Charles Dement from California, who is the founder of Sleep Research Center, formulated the first world sleep laboratory at Stanford University, USA. And he has defined apnea, hypopnea, apnea-hypopnea index, etc. So just to give an idea, what is apnea is cessation of airflow at the nostril and mouth, or more than 90% of obstruction for at least 10 seconds, in spite of the continuous respiratory effort. Hypopnea is reduction in tidal volume of 30% reduction in airflow, lasting for 10 seconds in the presence of respiratory effort, and desaturation of more than or equal to 3 to 4%, or arousal at the end of hypopnea. So there are the categories, the criteria are increasing and changing day by day according to the evolution and evaluation of the research work which is happening. So even 30, initially they were telling only 50% reduction. Now they say even 30% reduction in airflow itself can cause morbidity. But it is slightly different in pediatric OSAS. Here we say the cessation of airflow at the nostril and mouth for at least 2 breaths in the presence of continuous breathing effort. That means the respiratory rate is different because the age group here is different. Pediatric OSAS means from the age of 1 year up to 17 years, it is calculated as pediatric OSAS. After 18 years only considered as adult OSAS. So the respiratory rate is different. So we can't simply say more than 10 seconds is abnormal. So here we have to consider 2 breaths in the presence of continuous breathing effort. Same way, hypopnea, 30% reduction or more than or equal to 3% desaturation. So what we are finally looking at the value is apnea hypopnea index. That is the number of apneas and hypopneas happening per hour of sleep. So that will be calculated according to the total number of apneas happened during that night and total number of hypopneas that happened that night. Different types of apnea: obstructive, central, and mixed. So obstructive is there is a cessation of airflow in the presence of continuous respiratory effort. This is a respiratory effort which is happening, and there is no airflow. But in central, there is no airflow, no effort. There is no control. There is no signal from the central system. In mixer, it begins initially as central apnea. There is no effort. Later, the effort starts, but still the patient is not breathing. So this is a mixed apnea. For practical purpose, the mixed apneas are considered as obstructive apneas. So American Sleep Disorders Association classified and graded sleep apnea with AHI as mild, moderate, and severe. 5 to 15, 16 to 30, or more than 30 is considered severe. So there are few more definitions like respiratory disturbance index, respiratory effort related arousal. So all are basically started in the initial period. They were looking only at apnea. When the patient stops breathing, they thought it is very significant. Later they found that even partial obstructions are causing problems. So they included hypopnea. So first they said apnea index is very important. Then they included hypopnea also. So they said apnea hypopnea index. Then came RERA, that is respiratory effort related arousal. There is no apnea, there is no hypopnea. It is not fitting into the definitions what I gave for apnea and hypopnea. But there are some respiratory effort which is happening, which is maybe less than 30% of, not less than 30% of decrease in amplitude. But there are some changes happen in the EEG activity. That patient is waking up subconsciously. So that means the arousals are happening. So this arousal is the main reason for daytime sleepiness. This will happen in very early stage of the problem. So this is also causing problems. So that also being included along with the AHI and named as respiratory disturbance index. Right now, this is the uppermost limit of our issue. So in pediatric age group, it is slightly different. It has been described by Katz and Marcus as even they consider even one apnea per hour of sleep is considered significant. AHI less than 1 is normal. That means in 6 hours to 8 hours of sleep, if there is, for example, 6 hours of sleep, if there is 5 apneas, it is considered as okay. But if there is 6 apneas in 6 hours of sleep, it is considered OSA in pediatric age group. So 1 to 4 is mild, 5 to 10 is moderate, and more than 10 in pediatric age group is considered severe. So with these parameters, we are classifying the sleep-related disorder breathing as primary snoring, upper airway resistance syndrome, and obstructive sleep apnea syndrome. Primary snoring, there is only snoring, no other issue. The patient doesn't have any daytime sleepiness, patient doesn't have any morbid features. But at the same time, upper airway resistance syndrome, there is a resistance happening in the airway, which are noticed by mild desaturations and arousal or happening. I will explain it about it later. So in PSG is used to diagnose, rule out, and many types of sleep disorders, as I told you. It objectively records sleep stages. What we are looking at? We are looking at the sleep activity by ECG, EOG, and we are monitoring the cardiac function by ECG pulse oximetry, and we are monitoring the respiratory parameters by nasal and oral airflow, abdominal and chest movement. And we are also monitoring the movement of the patient, whether the patient is in which position when he is sleeping, whether there is any leg movement. So basically, we are looking at sleep, cardiac function, pulmonary function, and the body movement. the common question which is being asked is, what are the indications of PSG in children? When do you do in children? There is a big list. But in our day-to-day practice, if you ask me, are we doing it in all these conditions? Yes, we have to do in all these conditions. Not for routine obstructive sleep apnea, which is the obstructive adenotonsillectomy, which is the commonest reason. For example, even you have to do before decannulating a tracheostomy patient. So there is a big list, especially when there is a recurrence of snoring and choking after adenotonsillectomy in a pediatric age group. So most important thing is to have a child-friendly environment. If PSG is not possible in pediatric age group, audio taping or video taping, recording of how the patient is sleeping, or overnight just an oximetry, or just 2 hours of nap polysomnography even in daytime, or unattended home polysomnography or accepted. Sometimes, especially in children with chronic lung diseases, capnometry, which is very useful to monitor the hypoventilation, which is very common with infants and very young age group. So end-tidal PCO2 measurement or transcutaneous electrodes can measure the carbon dioxide level, which will give you an idea about the carbon dioxide level and hypoventilation which is happening in this age group. So there are various levels I was talking about PSD. That is type 1 is minimum 7 signals or leads will be used to do. That is called laboratory PSD, which is the topmost thing. If type 2 is almost same as laboratory PSD, the leads, everything, but only thing is it is being done at the home, which is an unattended study. Type 3 is a portable device with at least 4 channels to be recorded, and it can be done under supervision or without a trained personnel at home. Type 4 is just for a screening. It is just 1 or 2 channels of information, which is just a screening level. It is not useful for a diagnostic level. This is one of the oldest polysomnography machine with a lot of EEG leads, and this is so huge and gives report in detailed report of PSD. This is a smaller version where up to 21 channels we can do, and this is what we are using in our center, where we can do record up to 22 channels. And here, if you see, it is an extensive EEG can be connected. Like all the leads from the EEG can be connected and monitored. That will be helpful in patients with sleep disorders, etc. Most important thing is to get a study night questionnaire. That is, ask the patient how he was sleeping before and on the day of study, and how was it good, medium, or better. So how he felt on that day of study is also very important. That will give you an idea about when you are reporting. These are all level 3 devices, very small. We can, even with that, we can record up to 8 channels. Apnea Link is another kind, watch path, which monitors the changes in the peripheral arterial tone and blood oxygen saturation levels. This also gives an idea about the sleep stages, etc. So basically, with all these, we are going to record the sleep stages, respiratory event, cardiac function, body position, and movement. This is what I am repeating again. Right? So now we know what are the things we are routinely look at. But there are other parameters like blood pressure can be monitored, capnometer or video monitoring, especially with sleep disorders, pneumotachograph with the esophageal balloon pressure, which will help especially in upper airway resistance syndrome, or pH probe where it is associated, OSA associated with the LPR. This can be combined. So this is a screenshot of a sleep study raw data. We call it as raw data, and it is a 1 epoch. 1 epoch means 30 seconds. This screen, what you see is what is happening to the patient in 30 seconds. So here the patient is breathing 6 times, almost 1, 2, 3, 4, 5 and a half times he is breathing. 6 times you can say. And this tube measures the eye movement, and this is for chinning EMG, and these 4 leads for EEG monitoring. The patient is awake. You can see alpha wave, And this is for anterior lateral, right anterior tibial, and this is for ECG. This is to monitor the snoring level, and this is nasal and oral thermistor or nasal airflow cannula to monitor the nasal breathing, and these two for thoracic and abdominal movement, and this is a backup for abdominal movement. So, and here the last one is for saturation, which is which will pick up the oxygen level in the blood. So in URS patient, if the patient is slightly going into sleep, you can see the eyeball movement, and you can see esophageal pressure is being connected, and that is being used to monitor. So when there is an apnea hypopnea, where you can't, in URS, you won't be able to see proper apnea and hypopnea here. At the same time, there will be variations in the esophageal pressure, followed by changes in the EEG. There will be arousal. In CPAP titration also, we can do with the level 1. There we'll be able to see here. So here you see flow and tidal volume of the CPAP machine. I'm going a little slow. This is complete, as I told you, the complete list of EEG leads, entire EEG. And this is a report which you will be able to see the stages, arousal, respiratory events, oximetry, body. This is a complete screen shows what happened during that night. This is very important to see various stages of sleep, limb movement, desaturation, abstract events, central events, mixed, and hypopnea and desaturation. So here you see, this is 30 seconds, and this is from here to here, it is 1 minute. In 1 minute, he is having 2 apneas with 3, 4, 5, 6 breaths in between. This is a classical obstructive apnea. This is a classical central apnea. You can see there is no movement in the thorax and abdomen. I'm going a little fast as it is getting late. And this is a report where we see obstructive apnea events 85, central apnea is almost 37, half of obstructive events, and mixed apnea is 10. And the total number of apnea events is 1 or 2. And here, central apnea is 36, obstructive apnea is 78, mixed apnea is 20. So these are all very important to look how many central apneas, how many hypopneas, because the AHI will not differentiate how many central apneas, how many obstructive apneas, how many hypopneas. It tells one number that it is considering equal as both apnea and hypopnea. Hypopnea, you can see there is a reduction in the amplitude. It is not complete obstruction. You can see the wave pattern is slowly coming down. There is no flat line. There will be snoring during this time. Oxygen saturation, that's what the next thing we commonly look at, average oxygen saturation, lowest oxygen saturation level, and oxygen desaturation index, number of oxygen desaturations happening per hour of sleep. So attended study versus unattended study, this is a type 3 in home attended study. 4 studies clearly says that the sensitivity and specificity will improve when it is a laboratory study, even if it is a type 3 study. False positives and negatives will be very less. In type 3 devices are still accepted as for diagnosing OSA. Why it is not accepted? Because of the lack of EEG monitoring and lack of standardization, inability to perform CPAP titration, and scoring is most commonly automatic scoring system. So level 1 versus level 3, if you ask me, level 1 has EEG, so actual sleep time will be calculated, but in level 3, no EEG, so total recording time is used to calculate the AHI. So why it is very important? Because this, I will give a small example here. Just before that, I will explain what is TST's total sleep time. That is non-REM sleep, REM sleep plus movement. Sleep period time is sleep onset to last sleep phase. It includes the entire sleep period time. Whether he is awake in between is also considered as sleep period time. Time in bed is just switch on and switch off. That is time in bed. This is what commonly used in level 3 or level 4 studies. Sometimes sleep period time will be used in level 3 studies, but level 1 study only calculates the total sleep time or actual sleep time. So, for example, recording duration is 400 minutes. That means 400, more than 6 hours, 6.5 hours is being used to record this patient. Okay, so the sleep period time is 367 minutes. But the total sleep time is only 158 minutes. Remaining 200 minutes he is awake. So that means the AHI will become 24, will become 62. So that means the moderate level of OSA becomes a severe, more severe OSA, because the number of hypopnea is very less, 164 only. But he has slept only for 2.5 hours. So the AHI will become very high. So this is the importance of level 1 TSD. So this is where you have to know when to choose level 1 or level 3. This algorithm will help you. This is actually given by my friend Dr. Dipankar. And this clearly tells patient presence for evaluation of suspected OSA. Okay. So now the patient have high pretest probability of moderate to severe OSA. If it is no, then only level 1. If there is a moderate to severe OSA, you can ask the next question whether there is any comorbid medical condition. If it is yes, again it is level 1. If it is no, next question is whether there is any comorbid sleep disorder. If it is yes, again level 1. So in mild case of OSA, you can go for level 3. Without any comorbid medical condition or comorbid sleep disorder, you can go for level 3. If there is any associated of these features, better you go for level 1. Got it? So another thing, important thing to discuss here is sleep night study. So the volume of referrals for sleep studies is increased. So this is like 3 hours you do sleep study and 3 hours you do CPAP titration. But the criteria is AHI should be more than 40 in the first 2 to 3 hours of the study. And also the second half, the patient should have achieved a REM sleep during the titration so that it is complete. So the advantage, the patient has come to the lab only once, it is half expensive and you are making both the things at one night, but at the same time, it can lack accuracy if the patient didn't sleep well, you are disturbing the sleep by putting the CPAP machine in the middle of night and asking to sleep with a huge machine on the face. CPAP titration is
expiratory pressure and minimal and maximal pressure support settings. Incomplete without seeing the disappearance of apnea during sleep. So instruction for the patient: on the day of study, ask the patient to get up early in the morning and not
at least an hour before study. Caffeine or sleeping pills or alcohol to be avoided. Always better if we go through the entire study. After the test is completed, the scorer should analyze the data and interpretation is done by yourself with the list of and with the patient's proper history. There are various difficult situations because night to night variability is there. Negative first night test is insufficient to rule out OSA. If it is positive, if it is significant, you can take it as positive. If it shows that very mild and it is not correlating with your clinical condition, you may have to repeat the test. So what are the pitfalls? We are looking at the value AHI. Apnea, hypopnea has been given equal weightage. The duration is not considered. Even 10-second apnea or 40-second apnea is given same number. ODI is not considered when you are grading the severity. Sleep efficiency is not being calculated. Some patient may be having very less REM sleep or may be having too much of REM sleep. So that all not given important. And the positional OSA, and patient might have slept in left lateral position or in prone position, and the AHI might be looking very low. So all these are very important when you are looking at the report and grading. So what to read from a PSG? So as I told you, AHI, total sleep time, and the sleep efficiency and the hypnogram, and REM latency, AHI in supine or non-supine position, percentage of REM sleep, limb movement, total arousal index, oxygen saturation, and ECG summary, especially in patients with cardiac issues. So if you ask me what is the most important to see in the PSG report, this page, which will give you an idea and also will give you an idea whether there are any artifacts. So here the patient, you can see a lot of REM sleep, and during that REM sleep, there is severe oxygen desaturation happening. This clearly tells that the patient is having severe apnea happening during REM phase of sleep. So take a message, high index of suspicion will lead to increased recognition of this sleep disorder. Unless your mind knows, your eye will not be able to pick up and see. So clinical correlation is very important before reporting. Identification of central sleep apnea is also very important, especially when you are taking up the patient for surgery, and that could be the reason for your failures. Proper assessment and CPAP titration is also very important before prescribing a CPAP. AHI alone is not sufficient to quantify the severity of sleep-related disorder breathing. Thank you.
Thank you. Can you hear me?
Yeah.
Yeah. Thank you, Dr. Vijaya Krishnan. That was a fantastic shot in a nutshell. I'm sure you can go all day if you're asked to talk on polysomnography, but I think you have covered it beautifully in a nutshell. There are a couple of questions, but I think some of the questions...
Srinivas, can you switch on your camera?
Yeah. Because I think the tech team has switched it off.
You can switch it on. Yeah.
I think the tech team has to switch it on, but that's fine. So there are a couple of questions before I request the next speaker to speak. So I think if some of the questions would be very pertinent if the people who are asking the questions would sit through the next lecture, because some of these questions are very relevant to the next talk. So I think we should take those questions at the end of the session. But I think one particular question which is very specific to your talk, Dr. Vijay, is a question from Dr. Geeta from Bangalore. So her question is bedwetting an indication for polysomnography? Dr. Vijay.
Hello, can you repeat the question?
Yeah, the question from Dr. Geeta from Bangalore is bedwetting an indication for sleep study?
No, as per the criteria given by American Academy of Sleep Medicine or even pediatric physician, bedwetting is actually not an indication for a PSG, as I listed out in the PowerPoint presentation. Those are the indication suggested by, but definitely bedwetting could be a reason for, could be because of OSA.
Correct.
So we have to look for other clinical parameters, whether the patient is having any sleep-related disorder breathing or snoring or restless sleep. So all those have to be considered before, not just bedwetting alone, if you ask me. No.
Yeah, so as a standalone factor, it may not be, but if there are other contributory factors, I think it becomes a very good case for evaluation by PSG. So I think what I will do now is I will ask Dr. Marina Carrasco to please upload her presentation and kindly go ahead with her presentation.
So one moment. Yeah, I think. Can you see it?
Yes, very clearly.
Okay, so well, I start. First of all, thank you very much for your kind invitation to speak to you. I'm flattered because also because of your very nice presentation of me. I just do not consider myself such a big thing, but thank you very much. I changed a little bit the title of the presentation because instead of talking about just surgery, I want to talk a little bit more about treatment, if you don't mind.
Sure, absolutely.
So thanks again for the invitation, and I hope you like this presentation I've prepared. So how DICE helps in deciding the management of OSA? We know, we know that there are many treatment possibilities, and every day there are becoming more and more treatment possibilities in our patients, because, for example, nowadays there's not drug treatment that we use, but probably in the near future for some patients we could give them some drugs. We have the CPAP, that is the standard treatment, but we have positional therapy, we have mandibular advancements, we have to do them exercises and myofunctional exercises, and there are stents for the upper airway and hypoglossal nerve stimulation, wings. There are many, many things that we are seeing, and more that will come. So first of all, to talk about the standard treatment and DICE, CPAP and DICE. In the position paper, we say that it's not useful to indicate CPAP, and this is true. If the patient has a severe OSA or moderate with symptoms, the standard treatment should be CPAP, and to do that, you don't need DICE. But there are some articles that say that could be useful to titrate pressure, and I don't know if this is very helpful now in this time when you can, when you have the coronavirus and all that, and we have the aerosols and all that, but in some patients could be useful. Although I think the automatic pressure is better to titrate, but what it's useful is to show the cause of CPAP intolerance. And here we have a very recent article that has been published. You can use CPAP and DICE to see why CPAP is not useful in this patient, and show if you could do some surgery to solve it. Another treatment that we have is the myofunctional therapy. Strengthen the muscles of the upper airway is also a very good idea always, but we know that, for example, for this kind of tone-based collapse where there's no hypertrophy of the lingual tonsils, maybe the muscle tone has really importance here. If we see this, maybe we should tell the patient to do some functional therapy or something like that in order to improve the obstruction. Because we know that tongue-based surgery is not so useful sometimes in these patients. And the other treatment that we should keep in mind is the mandibular advancement devices. We know that this is very useful, and although you don't need DICE to indicate the mandibular advancement devices, you can do it with awake exploration and all that. We know that if we do DICE, increase in success can be done, because we choose better which patients are improve the upper airway. Also, DICE could show how to titrate or mandibular advancements, or if the patient has a problem or something like that, we can do DICE with the device on and see what is going on, the same as CPAP. So this is something that we have to keep in mind. And if the patient has problems with the mandibular advancement, we could do DICE to show what is going on. And now, just a little bit of introduction, we'll go for surgery. That is the thing that we like the most. So I always say that DICE is just another part of the puzzle of sleep apnea. We have the anatomy, and I've put this picture of the skull pain by Gogh because I think it's really important. And sometimes we as ENTs, we don't look so much at the skull and see if the patient has any problems with the bones and all that, problems with the anatomy, with the soft anatomy that we all know so well. And then DICE is another tool that is going to show us what is going on while the patient is sleeping. It's just a snapshot. It's not the full night sleeping and all that. It has his weak points, but it's a really, really helpful tool. And I believe that it's another piece of the puzzle of sleep apnea, and everybody should do that in order to choose the better treatment for the patient, or at least the better surgery for the patient, because it shows you what is going on the upper airway. So to do that, it's very important to watch the things that we presented in the position paper. It's really, really important that we do that in a right way. And we have to watch the upper airway for 2 or more cycles in each segment and for each maneuver. The patient, we should start evaluating when the patient starts snoring and not before, because if you are using propofol, many patients can have central apneas, and these are not very nice, and you don't have to see that. This bispectral index should be between 70 and 50. And as I say, maneuvers are important. Also, the localization of the tip of the endoscope must be in the choana to assess the velum, in the margin of the soft palate to assess the oropharynx, and just above the level on the tongue base to assess the epiglottis. And another tip is to stay in the middle of the upper airway, in the middle of the hole, because it's the only way you can see what is going on properly. This is not so easy when you are doing. We can see here circular collapse that is becoming more lateral when we go to the oropharynx. And at the rim of the palate, we see the epiglottis and the lower part of the tongue base, because actually, as we are going to see later, some of the collapses in the palate can be caused because of the tongue base that is pushing the palate backwards. So as I was saying, in order to know if it's the palate or if it's the tongue base, and also in order to know if mandibular advancement devices would be good for the patient, we have to do maneuvers. And this is my SMART maneuver to pull the mouth and to know what if the mandibular advancement device would be useful. And I like this one better than the other one that some people do like this, because this can awake the patient. You can see that before the mandibular advancement and after the peace level increase. So some of the possibilities that the upper airway is better is because the patient is more awake and not because of the maneuver itself. So this is why I like the other one, that I think that it's less painful and can be more useful. But it's not been tested, so it's something that you could do. Another thing that we can do is the nasopharyngeal tube. And this is quite a new maneuver, and I'm starting to do it now when there's collapse of the tongue base, to know if this tongue base could, the collapse related in the area of the lower pharynx could be related to the upper part, because as you can see, most of the patients have multiple obstruction, but after putting the nasopharyngeal tube and surpass this obstruction, 74% have partial improvement and 35% had complete resolution of the collapse. And this collapse resolution was mostly in the lateral pharyngeal walls, low in the oropharynx, the epiglottis, but the tongue base seems to be not so useful. So what the conclusions of this article is that improving partial collapse in the palate reduces the collapse of the lateral pharyngeal walls and the epiglottis. So not all the obstructions here need to be treated. Improving incomplete palatal collapse do not alter the morphology downstream. So if we see a collapse that is there but the palate is open, we should consider that this is a main problem. And tongue obstruction appears to be independent of the palatal obstruction, as we have already said. And as I was saying, this is a MRI images of one patient. Here, as you can see, the upper airway is completely awake. Here, the upper airway is closed. It is closed because the tongue is pushing the palate. Here, the palate is closing, but the tongue is okay. So these 3 scenarios we can have while we are doing DICE, and we can have to keep this in mind to interpret what we are seeing. So the $1 million here is DICE a good tool? And this, with here, DICE would have to answer these questions. So does it change the surgical plan comparing with awake clinical exploration? Because it doesn't, why should we do this? If it does, is it followed by an increase of success after surgery? Or are there something that we see on DICE that could suggest that this patient is going to be a success, or that we shouldn't do surgery for this patient, or think about other surgeries like MMA or something like that, because otherwise it's going to be a failure? So I did, with some colleagues, we did an article on this specific subject, and I suggest you to read it carefully, because many things that I'm going to speak are very more deeply thought here, written here, so it's important. About the change of surgical plan, the latest meta-analysis said that it does change surgical plan in more than 50% of the adults. Nevertheless, it doesn't change the indication of surgical plan when it's in the velopharynx, or could lower their indications, which is not surprising because most of the patients show velum collapse when you are doing DICE. So it doesn't change. Changes surgical plan for the tongue base and the epiglottis. But we have to be careful because, as we have seen, not all the collapses in these areas need to be treated, so it's tricky. So DICE promotes or avoids multi-level surgery. It's not clear because not every tongue base or epiglottis collapse, as we are saying, need to be treated. If there's a complete collapse in the velum, the collapse can change downwards, if this collapse is solved after surgery, of course. But when the collapse in the velum is not complete, it doesn't change. And it's all a matter of fluid dynamics that we always have to keep in mind in our minds. So does DICE improve surgical success? Some of the articles that have been published, some are completely pro that DICE increase success. Some are completely like, we shouldn't do DICE because it's useless. But so far, there are no randomized controlled trials. And we know that this is the best quality. So we always have to keep in mind that most of the studies have important bias, and we have to be careful with the conclusions. And this is an important idea to know about selection bias. This is a report of my patients, surgically treated patients. These are the proportion of surgical Friedman, let's say Friedman 1 patients, TAC. This is Friedman type 2, this is Friedman type 3. And you know that Friedman type 1 have 80% or higher percent of success. Friedman 2 is only 40%, and Friedman 3 only. Sorry, this is Friedman 3. Friedman 2 or 10%. So if my sample is closer to here for Friedman 1, I'm going to be a really successful surgeon, but I'm leaving out many patients that could improve with surgery. Maybe not with cure, but could improve. And in the other part, if my sample size is here with all Friedman 3, I'm going to be a really bad surgeon, or maybe not, but my patients are more difficult. And this is a problem that all the articles have so far. So we have to be careful with conclusions. The article that goes pro, that I like the most, is this one by Huntley. And they did a retrospective study in 87 patients in 8 years. And they compare DICE and no DICE patients. And the patients have no difference in basal characteristics. DICE in their series decreased multi-level surgery, 8% on DICE versus almost 60% in no DICE, and increased surgical success, 80% versus 61%. But this was tricky because they were doing in the second part hypoglossal nerve stimulation. So they excluded this patient with hypoglossal nerve stimulation, and the better results remain because post-apnea-hypopnea index was better and surgical success still was better. So in this series, doing the same techniques in every patient, excluding hypoglossal nerve stimulation, we could see that the DICE was useful. And this is the article that says that DICE is not useful. And this is a prospective 7 countries, not randomized trial with more than 300 patients. So it's a big sample size. More or less half and half, a little bit more DICE than no DICE. You can see that pre and post here, surgery, the apnea-hypopnea index was more or less the same, no difference, but the apnea-hypopnea index post was better in the no DICE group. And the apnea-hypopnea change was better and the success rate was better. So apparently DICE in this article is useless. And the success rate according to mild or moderate or severe OSA, we can see that there was an increase in success rate in mild and also in severe, but not in moderate. And the success rate according to share was more or less the same, except in severe OSA that was better in the no DICE group. And we can see that when they look at the surgeries that had been performed in the DICE and the no DICE surgery, there's a difference in the tone-based surgery, that it was more common in the DICE group than in the no DICE group, and the no surgery was more common in the DICE group, in the no DICE group, sorry, than in the DICE group. So their conclusions was that DICE, of course, doesn't show better results. DICE may over-indicate tone-based surgery, and the changes in the upper airway dynamics due to an increase in nose surgery in the no DICE group may be responsible for the better results. Talking about fluid dynamics, here we can see a very recent article published by Suzuki this year. We can see here nose breathing and how is the velocity and the static pressure. When we open the mouth, it doesn't change that much. But when we have mouth breathing, the velocity, the speed of the air increases, and so the collapse in the upper airway. So it's really, really important that we treat the nose and that we solve the nose problems in order to have a better breathing and to solve the collapse. Another question that we had to answer is that DICE was showing something that was related to success or failure. These are the articles that have been published. Some say that are good for choosing tonsil collapse, AP collapse, partial tongue-based collapse. Bad signals for surgery are the velum CCC, tongue-based complete AP collapse, severe lower pharyngeal collapse in the area of the tone base, or epiglottis collapse. Regarding hypoglossal nerve stimulation, of course, the CCC or even the lateral collapse at the velum in complete collapse in the epiglottis. And I'm going to show you this article that is the highest number published recently. It's a multi-center study with 275 videos that were reviewed blindly. And they excluded tonsils 3 and 4. So this is all R. Friedman 3 and 2 patients, difficult to manage. The oropharyngeal wall related collapse had poorer surgical results with an odds ratio of 0.51. Complete tongue-based collapse have lower O rates surgical response, but just in moderate and severe OSA. There was no clear association with degree and configuration of the velum and epiglottis, but no patients with epiglottis as primary site achieved success. There was surgical response that was inversely associated with tonsil size and BMI, of course. And the surgeries performed, you can see that 93% of them were palate, but only 35% of them were isolated. So there was a lot of multi-level surgery. And despite of the high number of videos, there was a lack of statistical power in complete versus partial collapse, for example. There were not better results, no significance. The surgical success was lower if the primary site of the collapse was the tongue base, but had no significance. But when the surgery was done here in the tongue base, were better the results in saying that tongue base has an effect. It was impossible to perform correlations between the type of collapse in the velum and the type of surgery. So could we say, because now there are articles that says that with some, we know that with CCC, the success rate is really low because 80% of the patients have bad success with classical UP3, even though the collapse does change after UP3 and is not longer the CCC. But there's two articles that say that it responded after the limited palate muscle resection or the Iassa technique performed at Mantovani. One note, no patient with partial velum collapse improved after limited palate resection. And what these two techniques share is that they do resect some part of mucosa in the center of the palate, and then they do applicature here in the muscle, like here. So this is what they have. And I want to show you this small video, previous tonsillectomy, this patient, and this is the endoscopic side of the patient with just in the OR with anesthesia. You can see that there was very, very little space anteroposterior here. We performed the tonsillectomy. Here you can see very nicely performed. And the collapse is a little bit worse because of small edema. I did this barbed suture on the lateral side, but on the left, to see here, more edema, but as an improve that matched the upper part of the collapse. Here there's nothing because I just did one side and then checked. Then I did this suspension sutures that because Agrobal was speaking the other time. And you can see, sorry, because I didn't remove the bleeding and it's not so well focused, that space has increased better. You can see that. Sorry about the focus. But then I did this zigzag suture that I like very much. And you can see now when it's focused that the velopharyngeal space increased better than with the other suture. The upper airway was open. So it's true that we can use dice and decide, but this is still work in progress, so we have to be careful with things, and we always have to keep in mind the bias that we can think consciously or unconsciously. So thank you very much for your invitation, and that was it.
Can you hear me?
Yes.
That was a fantastic talk, Dr. Marina. Really enjoyed it, and I'm sure all our colleagues who have gone through the lecture must have enjoyed it. I should also say it's a very, very balanced talk. There are lots of insights into it. You've sort of balanced out the pros and cons beautifully. Do you have some time for some questions?
Of course.
Yeah, sure. So one of the questions was, I think he's not put it properly, but the question is, if you were in a case of a complete concentric collapse, I think he's talking about CCC on dice, with the tip of the scope at the velum, can you predict the topography of the downward collapse after surgery is the question.
I'm afraid you can't.
Yeah, exactly.
I'm sorry.
Yeah.
You can try to use the nasopharyngeal tube to know what is going on, and to see if if you solve the problem. But you know that be careful with this CCC, because you must choose your technique with this. They are saying that the best thing you could do with this collapse is MMA, but as I show you, there are other techniques that can be useful too. Just
Correct.
keep that in mind.
So the other question is that in this era of DICE, what is the role of Muller's maneuver in deciding surgery?
I don't do Muller's maneuver anymore. I've changed it by the simulator snoring, that it looks like it's more like dice, but I don't know. It's there can be surprises all the time. Sometimes it's similar, but the other time it's not. So I don't know really. I like dice. I like doing dice. Yes, I'm a pro dice woman, so.
Yeah, this is, there is some literature that actually said that if your obstruction were to be only at the level of the palate, Muller's and DICE do correlate. However, Muller's can do nothing for the lower levels of collapse.
Yes, but as I said, not all the collapses that you are watching in the tomb
Marina
need to be
Carrasco
treated.
Spain থেকে আজকে বলছে দেখো ড্রয়িং রুমে পেছনে ম্যাগনেট আটকানোর দুটো
What is, can you please mute your
মানে গোটা পৃথিবী থেকে ঘুরছে তো ম্যাগনেট কোনো মনে হয় না
Dr. Dipankar,
কোথায় কোথায় ঘুরেছে
Dr. Dipankar, can you please mute your mic, please? Dr. Dipankar, can you please mute your mic, please?
Dinesh?
Now.
Yeah, thank you. Sorry about that. Very sorry about that.
No, it's okay. It's okay.
Yeah. So, and then the other question was, can, and I'm sure you must be getting this question all the time, can DICE be an alternative to polysomnography?
No, dice cannot be an alternative to polysomnography. As I just said, it's just 15 minutes. 15 minutes, even if you are watching N2 phase, that is where most of the apneas and hypopneas occur in most of the patient, is not enough. You need okay, a surgeon is his own judge, meaning that you have the pre and you have the post. So you need to know how well are you doing, and the only way to see that is in the PSG, I'm sorry, or a sleep study. It's not a substitute. It's another piece of the puzzle. It's not.
Yeah.
It's
I
just
think
that.
that's very beautifully put. And the last question before we take the other talk is that what is the future of DICE in the COVID era?
Well, I think if you can do surgery, you can do dice. Absolutely, because surgery has the same problem with spreading all the things. But maybe we should be more careful and put mask in the patient to do dice more safely. But if you can do surgery, you can do dice.
So I think at this point, I can only allow so many questions. There are many more, but is it okay if we can go to the next talk? And would you be available for further questioning, or do you you need to go to the hospital?
No, today is a free day in Spain. We don't have to work, so I'm here just.
Excellent. So then I'm going to hold you on for some more time, please. And I would request Dr. Vikas Agarwal to start his next lecture, titled Nitty-Gritties of Drug-Induced Sleep Endoscopy. I'll come back to you, Maria. Thank you.
A very good morning to all of you. My sincere thanks to once again to Sun Pharma and Srinivas Kishore to moderate this session, Sun Pharma to support the series. And my talk on nitty-gritty of drug-induced sleep endoscopy classification systems. So I believe, are you able to hear me well, Kishore?
Yes, yes, very clear.
Okay, are you able to see my slides now?
Yes, yes.
Okay, so why are we talking on drug-induced sleep endoscopy classification systems? You just heard, Maria, that drug-induced sleep endoscopy, though it is controversial, but still it is the in thing. It is the most logical thing that has happened to diagnosis of levels of collapse in sleep apnea. And like any work in progress, as she said, drug-induced sleep endoscopy classification and documentation and communication is also is a work in progress. So whenever a new thing is discovered, it takes some time for the world to, you know, go to the next level, understand the nitty-gritty of it, and then come to a final solution. And we are definitely looking at a final solution in coming years. So we all know obstructive sleep apnea is a disorder which is multifactorial. One of the factors is anatomy. One of the factors is body physiology, the BMI of the patient, and many other things. So in anatomy, there are multiple levels. So it's not only multifactorial, it's also multi-level. So now you're dealing with too many variables, lot of factors and lot of levels. And what is happening is everybody is trying to fit it their own way. So this is a local Kirana store where you can see this shop owner, he knows where everything is kept. And if he's sitting on the shop, he will give his customer exactly what is needed. But the day this Kirana shop owner is not at his shop and somebody else tries to handle it, he will not know anything because he would not know what is kept where, because there's no catalog, right? There's no way to know what is there. Everything is there in the mind of uh, the Kirana shop owner. So what is needed is to catalog it. You know where a particular item is kept and then exactly where to look for it. Similarly, there are thousands and thousands of books in library, but it's very easy to pick out a book if you have the correct catalog, if it is properly cataloged. So that is the necessity of making a classification of drug-induced sleep endoscopy. So this is a very nice paper of 2017, which reviews systemic review and meta-analysis of all the papers which have come upon the drug-induced classification systems. And right from 1991, when Croft and Pringle described drug-induced sleep endoscopy, till 2016, there are a lot of classification systems which have been described. So I'll not go into the detail of each system. What I would suggest, when you look at the Croft and Pringle system, they have only grouped into group 1, group 2, group 3, which is palate level, single level palate obstruction, or multi-segment problem. So from simple classification, because that was the most obvious thing which comes to their mind at that time when the thing was initially described, to the systems becoming more and more complex because more and more factors were identified as and when the time passed. And as you see there, from 1995, there are two systems again on the same way. Then you go to 96 to 2003. And from 2003 to 2011, there was a big gap. So till 2003, whatever is described is very, very basic. And then in 2011, Eric Kazarian, our friend from LA, he came out with vote classification, which is one of the commonest classifications used till now. And then our own professor, Dr. Vicini from Italy, in 2012 came with the NOHL classification. So in vote classification, Keresian looked into the dynamic problems, dynamic part of the collapse. He did not take into account the static part of the obstruction, which Vicini classification did take care into. And then this is a pretty more uh, elaborated classification by Herzog in 2015. Then Carasso, Marina just talked about, she also has a classification system. Then 2016, Weir has given a classification. So we know that there are a lot of classification systems. But what is the conclusion of this paper? That there is no currently universally accepted DICE classification system. Furthermore, there is no currently universally accepted framework for devising a treatment plan. And I'm sure Marina just talked on that, because there's no consensus. Why there is no consensus? In spite of a technique which is promising, which is good, why there is no consensus? Because the consensus is not there because this is the story of a elephant in the room with many blind men looking at it. So every blind man has an area from his trying to describe the elephant. So somebody is describing it as a fan, somebody is describing it as a snake, somebody as a wall, somebody as a rope, and somebody as a tree. So since we all are describing the same problem of obstructive sleep apnea from our points of view, and there's a subjectivity involved, because we have our biases, as Marina just said, we have our biases, and we have to eliminate the bias. We have to know the entire picture, not a part of the picture, and we have to eliminate the bias. So we have to develop a system where there's a methodical way of getting into the system. There's a methodical way of sampling, and there's a methodical way of communication across the colleagues. Now, when we talk of communication, from 1991 to 2020, communication has completely changed. See the way we are communicating now. Marina is sitting in Spain, I'm sitting in Mumbai, and my friends are sitting in Hyderabad, Chennai, and we are communicating just in real time. So internet has changed everything. So we have to understand our ways of thinking will also have to change. We started with emails. Emails have become really sophisticated. Then we went on to WhatsApp. WhatsApp is the commonest platform that people now communicate on. And then we put our documents onto Google Doc, and everybody can, access, make changes, and everybody communicates on Google Doc. So things are changing, and this is not the only thing. Things are going to change in the research methodology also vastly. People are not going to, no more we are going to sit and review papers and write review articles and this and that. This is all going to change. AI will take over everything. So what I'm suggesting, we change the word classification of a limited type to a comprehensive reporting system. So we know that there are a lot of variables in last, say, 30 years, from 1991 to 2020, 29 years. We have known that right from nose to nasopharynx to palate, different parts of the palate, to oropharynx, to base tongue, to epiglottis, and then some factors like BMI and AHI and different parts of AHI. There are a lot of factors which are responsible. So it is impossible for anybody to just classify that big problem into small things. So we forget about the easy. Why this classification system was made? To have easy communication, VOTENOHL. So let's no longer talk about that, because we are not going to pick up the phone and talk to other person. Okay, he was N1, N2. We're not going to talk like that. We are going to, even if you're going to call, we'll say, okay, I'm sending you a WhatsApp. Even I'm going to send you a report. Just have a look and opine. So the idea is not to talk. Idea is to take a second opinion. Idea is for Marina to understand, if I am sending reports of a case to her, to get a complete idea of what is happening. And then she can communicate to Srinivas, and Srinivas can communicate to Vijay. So the idea is that we all communicate in a comprehensive way, so that the information is passed on completely. And that's where, if we are trying to develop a system, Srinivas and Kishore, we are trying to develop a system that if every person, every worker, every scientific mind, if he enters the relevant data objectively into the system, so we can have an app, we can have a Google Doc, we can have something which the OT assistant can fill in. You can fill in, just touch screen. We are working on that, and we'll come out with multiple platforms. So if we can only put the correct data entry points, then this situation which I described earlier will not be the case. And once you objectively give inputs in form of complete and correct data, then matter is solved. It should not give rise to any subjectivity, and rest of the work can even be done by artificial intelligence. First, we can communicate each other very objectively, and then even the research can be taken care of by the artificial intelligence. It's a world pool where artificial intelligence can conduct automatic objective research, and all the contributors can pull out data which is meaningful without anybody actually going into partial research. It will be comprehensive research. So this is an idea with which we are developing this module. Now, how do we do drug-induced sleep endoscopy? We pass an endoscope inside the patient's nose, and we monitor it with the drug-induced, the BIS monitor. So when we go inside the nose, we look at the septum, we look at the turbinates, we look at nasopharynx, we look at all the variables of the nose. This is the turbinate hypertrophy in the right side, and then we give different types of medicines. I'll not go into that. So we obviously look at the BIS in different ranges, 60 to 80, 50 to 70, whatever you want to take. Then we know that nose is again very important. Now, if this patient who has a BMI of 37, AHI of only 13 with a bad deviated septum and polyps, and thin palate, tongue is not bulky, what treatment will be most effective? Obviously, he does not require a sleep apnea surgery. He just requires a nose surgery. That's it. So though he's technically a patient of obstructive sleep apnea, because the AHI is 13, does not mean that he requires a pharyngeal surgery for sleep apnea, because this is a static obstruction. So nose again is very, very important part of it, as is larynx, as is base tongue, as is soft palate. So idea is that once we understand the path of the airway, it enters from the anterior choana and passes onto the pharynx through the posterior choana, traversing through the nose. And there are various structures. Adult adenoids, again, very common. So why don't we look for adult adenoids in every patient? Turbinate hypertrophy, the posterior end of the inferior turbinate. The turbinate hypertrophy is again described in different forms. The turbinate hypertrophy, deviated septum, even ethmoiditis, if for that matter, uh, seen on the CT scan. Then we reach the choana. This is the upper end of the velopharyngeal tube. Now we understand that velopharynx is not a sphincter, it's a tube. It's a vertical tube. So in so many years, we thought that velopharynx was just a sphincter. So we could describe it in a two-dimension AP lateral circular. No, it's a tube. It has got an upper end and lower end. And it has already been described by various researchers in different ways. Now this is the upper end of the tube. And if you look at the whole tube, just give me a moment, I'll optimize the video. I'm stopping the share. I'm starting the sharing again with computer sound and optimize share. Okay, now you'll get the sound. So if you look at the drug-induced sleep endoscopy, in this case, the upper part of the tube is very wide. It's only the lower part of the tube which is collapsing and causing snoring and sleep apnea. So we have also now understood the way the various structures work during sleep apnea. This is the movement of the tonsils and the associated structures in the AP direction. When we look from anterior to posterior, this is the way tonsils are moving upward, medially, and posteriorly. So if we cannot obviously see the posterior movement from this direction, so we'll see it from this perspective. And we know that which is the area which goes at the back and compresses. So this has given us a lot of understanding in this velopharyngeal tube. You can see the path of the air, and this tube is behind the soft palate, and it's a tubular structure. It's not a two-dimensional structure, it's a long tube. So it has got an upper part and a lower part. And we know that this tube, the upper part of this tube, is responsible for swallowing. This is the swallowing movement seen from the nose. So swallowing is caused, the velopharyngeal sufficiency during swallowing is the responsibility of upper part of the soft palate, which is levator palati. So this is the levator palati function. Whereas You can see the levator palatii function as blue line on this. This is the upper part, whereas the collapse is only in the lower part. And this is the situation which happens in 90% of the cases. Right. So this understanding has led us to a comprehensive analysis, and this is we are proposing, we are writing a paper, and we are on the job is in making a app an app which everybody can download on Android as well as Mac, Apple, sorry, iOS. So this we have called VSV dice reporting system. Why VSV? Because it was my idea to start with, and has been supported by Srinivas and Vijay, and all the three of us are working on this system. So we have called it Vikas, Srinivas and Vijay, VSV dice reporting system. The basics will include name, age, sex of a patient, address, contact number as it comes in your own uh, uh, records. Then what drug you have used, dexmedetomidine or propofol, or you can enter whatever else you have used, how much. Then BIS monitoring done or not done. If done, what was the range? Because obviously there's no one uh, number of BIS that you can give. You can give a range. You took the recording between 60 to 80 or 50 to 70. And then there will be one page for BMI, AHI, or even the whole polysomnography report, the PDF of that to be included. Then basic questions on in the history like comorbidities, daytime sleepiness, diabetes mellitus, hypertension, thyroid, basic Malampatti score, so that one understand what we are dealing with, so that without examining the patient you can, and there'll be an option to include your pictures, the clinical pictures into that page, so you'll be able to see everything and you'll not have to examine the patient in person, as we do not have to sit across in one seminar room to have this online webinar going on. Then the next page would include findings of the nose, such as the nasal septum, whether it is straight or deviated, it is deviated to the right, deviated to the left, whether it is high, low, anterior, posterior, whether it has got a septal swell body, and then the grading of the deviated septum, which there are many papers on, as grade 1, 2, 3, or any other thing if you want to put a note. Then inferior turbinate hypertrophy. Generally, we put the scope once before decongesting the inferior turbinate. So what is the status then? And once after, if we put the decongestion, then what is the status? Why is it important to decongest? Because by decongesting the inferior turbinates with adrenaline solution or even xylometazoline solution, you simulate nasal surgery. So what is going to happen after nasal surgery is going to be seen after decongestion. And this is just like if there is a wax in the ear and you try to do impedance, you'll not get to know what is the status of the middle ear. So you remove the wax and then you can do the impedance. Similarly, if you decongest the nose properly, then your nose is actually out of, it's not more, even if with the septal deviation, it will not interfere with your resistance. The resistance will be lowered and you can see what is happening in the the oropharynx, the laryngopharynx. So this point was taken. Then how big is the middle turbinate? If there's a huge concha bullosa, obviously the airflow you saw was abutting the middle turbinate. So if the middle turbinate is large, again that would require a treatment for any patient. So nasopharynx, adenoid hypertrophy or not, if there's anything else or not, you'll always have an option to type something extra that you have seen, which is not there in the standard case. Most important part. Velopharyngeal tube is divided into upper and lower part. As I said, upper part is the part where your swallowing is happening, where levator palatii and the tensor palatii are working. And 90% of the cases, upper part is not involved. It's only the lower part. But in the world classification systems, we have only described AP lateral circular because that is the thing happening only in the lower part. And Velam also has upper part, and I think Dr. Woodson has already described the high palate where the upper part of the palate is going behind. So upper velopharynx, we are combining everything. So anteroposterior, as in high palate described by Dr. Woodson. Lateral pharyngeal, lateral part of the upper velopharynx. Salpingopharyngeal fold is clearly described now. We described it first in 2012. Now, all my colleagues across the globe are confirming that they're seeing in almost 20 to 30% patients, they are seeing some grade of salpingopharyngeal fold hypertrophy, which is obstructing the upper part of this tube. And therefore, it is important to grade that, and we graded that last year by our paper in the Indian Journal as Agrawal's grade for salpingopharyngeal fold at 0, 1, and 2 when it is less than 25%, 25 to 75%, or more than 75%. Then we come to the lower vilopharynx, and as it has been aptly described already by my friend Eric, AP, lateral and circumferential, again graded into 0, 1, and 2 is the thing. So if the vilopharynx, which is more than 95% of the patients have vilopharyngeal obstruction, can also be classified into upper and lower. And this is very, very important to understand. Because vilopharynx, as you said, as you can see here, sometimes is in the form of a funnel where the upper part is not obstructing, only the lower part of the obstructing, which is 90% of the case. And as you can see here also, and sometimes it's in the form of a tunnel where it's like a tube. Even the upper part and the lower part both are obstructing, as you can see here. Sorry. Like you can see, even the both upper and lower part are collapsing. So this is example of an upper high palate obstruction. This is the salpingopharyngeal fold hypertrophy, which was described by me. You can see the salpingopharyngeal fold completely obstructing the upper part of the vilopharyngeal tube. So now whatever surgery you do on the lower part of the vilopharyngeal tube is not going to take care of this upper obstruction, which is caused by the salpingopharyngeal fold. And therefore, this grade 0, 1, and 2. Grade 0 is when there's less than 25% of the area is occupied by the salpingopharyngeal folds. Grade 1 is between 25% to 75%, and grade 2 when it is more than 75%. Then we come to the AP collapse. Now, if you can see here, this is a classical AP collapse described, right? This is anterior, this is posterior, so this is the AP collapse. But what is happening here, if you see this video from the beginning, what kind of a collapse will you call it? Lateral, right? If I give you this picture at this point of time, you'll call it purely lateral. If I give you this picture, I'll play it again. You may call it circular. So, and then this one you'll call it AP. So we know that during, even in a single patient, during different phases of DICE, the predominant collapse keeps on changing. The collapse keeps on changing. So we take care of the predominant pattern. So this is AP pattern. This is lateral pattern, because this is the lateral action, and this is the circular pattern. So this remains as it is, but we have to understand that there's a limitation to that also. And there are other factors like the oropharyngeal wall. So oropharyngeal lateral wall, lateral oropharynx does not have a anterior wall. It has a posterior wall, which generally does not collapse. It has a lateral wall, which collapses. Now this lateral wall of the oropharynx is also divided into anterior and posterior part. Anterior part is by the tonsils, and posterior part is behind the tonsils. So this has not been described as yet by the world classification. So we have included this anterior part, which is made by the tonsillar hypertrophy, grade 0, 1, 2, 3, as it has already been described, and the posterior part, which is the lateral pharyngeal wall behind the tonsils. So I'll show you again that lateral pharyngeal wall collapse is graded at 0, 1, and 2. Now, if you see this video, now this is the tonsil, this is the uvula, and this is the anterior part, the part of the this is the tonsil. This part is the anterior part, but this whole part behind the tonsil is the posterior pharyngeal wall. Is the lateral pharyngeal wall in the posterior aspect, and this is the posterior pharyngeal wall. So the lateral pharyngeal wall behind the tonsils also contribute to collapse, and that is also to be taken care of, because there's no surgery so far described to take care of that part. Then we come to base of tongue. it can again be upper part of the base tongue, lower part, or the entire base tongue. By Moore's classification, it's already been described. We have just made it simple by saying upper, lower, and entire. What is upper? From foramen cecum to the tip of epiglottis is upper, and from tip of epiglottis to the vallecula is lower. Then we have to describe it whether it is lymphoid, muscular, or both. And then the collapse, whether it is AP or lateral. Generally, it would be AP only, but sometimes it could be lateral also if the whole tongue base is collapsing by the lateral hypertrophied muscles or lymphoid tissue. So here you can see a high tongue base collapse. So you can see that this high tongue base is also collapsing onto the soft palate, as well as this high tongue base collapse is above the level of the foramen cecum. You can see the filiform papilla above, and the lymphoid tissue is behind. So this is a high tongue base collapse. And in contrast, unfortunately, this is not working.
Vikas?
Yeah.
We just have 5 more minutes because there are lots of questions.
Okay, fine,
so you just plan your talk accordingly.
Correct. So this is the low tongue base collapse, though this video does not seem to be working. But this is the low tongue base collapse, and then you can have a both high and low tongue base collapse, where both muscular high tongue base as well as the lower part of the tongue base is collapsing. And then there can be completely lymphoid base tongue like this. This is purely a lymphoid base tongue, though it's huge. You can see the lymphoid tissue. Or you can have a purely muscular base tongue. Then lateral hypopharyngeal wall. Besides the tongue, if the hypopharyngeal walls are collapsing, because higher advancement is the only surgery which can pull the whole thing forward and take it laterally. And then we go into the larynx, epiglottic collapse, whether it is primary or secondary. Primary is when it is the only epiglottis. When it is secondary, that means it is with the base tongue. 0, 1, 2, depending on the collapse, whether it is complete, as 1 it is incomplete, 2 is complete, and 0 is nothing. Supraglottis involvement is also taken care of. So this is a primary epiglottic collapse. Only the epiglottis is collapsing. And this is a secondary epiglottis collapse. I think this video has some problem. So this is because of the base tongue. Then, as Marina said, that it's very, very important to do DICE with interventions. Ashmark maneuver she already showed you. Nasopharyngeal airway use she talked to you about. So we see that we have done interventions like closure of the mouth and see whether the base tongue is improved or not improved, because based on that you'll do the surgery. Ashmark maneuver, nasopharyngeal airway use. So when you use the nasopharyngeal airway, you bypass the nose, you bypass the soft palate, and it simulates the nasal and the palatal surgery, so that you can see what is happening in the base tongue and the hypopharynx and the epiglottis, and you can decide what surgery you have to use. So here you can see this patient. I don't think we have time, so we'll just skip the videos now. This video you can see how you put a nasopharyngeal airway and see what is happening into the base tongue when the palate is kept open by the. Now you can see this epiglottis collapse is not complete when you keep the soft this airway open by the tube. So you need not operate on the epiglottis of this patient. So then one positional variation, our friend Dr. Nico de Vries has a lot of work on head rotation, positional OSA, positional variation. So we do that also. We do both head rotation as well as head and body rotation. And we sometimes do a DICE through the mouth, as my friend Srinivas Kishore, he does a DICE through the mouth. So we include everything, and then there's a thing for putting our notes that if there's anything specific that we have noticed or which is something beyond that we have put in this thing. So that is the my presentation. That was my presentation on the nitty-gritty in DICE and how we can comprehend everything by putting it into perspective and by objective entry of data and objective analysis by our friends across the world. Thank you.
Thank you, Vikas. I think that was a fantastic deliberation based on the time that's given. I think you've done the best that you can. Thank you very much for those very clear-cut videos. So all the presenters, can I hear you? All the presenters, are you guys in?
Yes.
Yes. So first of all, I would like to congratulate our dear friend Rodolfo Lugo. It's 1 o'clock in Monterrey, Mexico. He's listening to us.
Hi,
Rodolfo.
Rodolfo.
So he's put pictures of everybody. So yeah. So let me just take questions one thing at a time. The first question is to Dr. Vijay, I think, because you started it. The question for you is, what kind of systems that do you use for your polysomnography? A few words about the system that you use.
I use both level 1 and level 3 Sleep Med, which I showed in my presentation. So that has a wireless connectivity also, which can be used for both level 1 and level 3.
All right. And the question that is attached to it is, when do you do level 1 for all your patients?
No, that's what I clearly made an algorithm. So only patients with both, as per the algorithm, with comorbid conditions or with comorbid, the pre-test is the one which is very important to decide how much probability he may be having for OSAS, and according to that, whether it's yes or no, and other comorbid features and other comorbid sleep disorders if you suspect, or if simply to say, if you think it could be a mild case, and if you think the patient will be having a lot of sleep disturbance, where you want to know exactly the total sleep time, actual sleep time, then I would prefer level 1.
All right. I think that sort of answers the questions for that. There's just one more question, and I think you will be the right person to take it, because you've sort of given a talk that is the question is, should oxygen be added to the BiPAP in a known case of obesity hypoventilation syndrome? I think it really doesn't come into this topic, but I think you should just take that and answer that.
Yeah. Anyhow, we'll be having a detailed discussion on CPAP and BiPAP management later in the series.
Yeah.
But all depends upon how is the desaturation happening. If it is really low, and sometimes COPD patients may be already using regularly oxygen at night, and adding oxygen will definitely reduce the carbon dioxide retention and the sleep. So adding oxygen is helpful, especially in COPD patients.
Yeah, I think, and then I think we'll have a separate talk on OHS. So
one point which I would like to add, this is where titration will be very important. So if you just give a CPAP and still if the oxygen saturation is not improving, the patient will not be feeling fresh. So when you do a CPAP titration along with a PSG, you will know whether the oxygen level is improving or not, whether the central apneas have disappeared or not. So all those data you will get when you do a CPAP titration or BiPAP titration.
Okay. So Vijay, thank you very much for those answers. The next question is to Dr. Maria. Okay, so there are a lot of people who have actually appreciated your talk.
Thank you.
So the question for you is, what is the best preferred drug for drug-induced sleep endoscopy? And your preference?
My preference is TCI propofol, but I have to tell everyone that I'm biased because I've never used dexmedetomidine, so I don't know how this drug really is going on. But I like TCI propofol.
Okay. Any particular reasons why you don't like dexmedetomidine?
Well, it's more expensive, so that's something you have to keep in mind. Takes more time to achieve the sedation. Another thing you have to keep in mind. If you don't have the patients sleep deprived, they may not fall asleep just with dex. That's something else. Careful with patients with problems with cardiac problems and all that. You cannot use atropine. Yeah, these things, but actually in Spain it's not available. You cannot use it, it's not allowed. So that's why I don't have any experience. I would like to, but any time I talk to my anesthetist to use DEX, they say it's not allowed. So no questions.
So I think
Okay.
Srinivas, Dex
So I think,
we all are using Dex. So Dex is a very nice drug.
yeah.
You can speak about Dex if you want.
Yeah, so I think there are pros and cons for DEX. There's a beautiful paper written by our colleague Sandeep Bansal from PGI Chandigarh, where he compared DEX and propofol. And his thoughts are very similar to your thoughts, especially in a busy theater, because DEX takes a lot of time to induce. Somehow I feel that DEX has some kind of a respiratory protective mechanism, because yes, that it's not only safer, Vijay. I think it does not allow you to hit that LSAT that propofol allows you to hit. It takes a way long time to hit that lower saturation. Then when it comes to propofol, you are bang, you're there, you're seeing it, you're out. But I think Dex is a more stable medicine that way.
So I would like to just add here about DEX that Srinivas, 90% of the sleep is non-REM sleep. And the
Correct.
LSAT that we see in the sleep study is generally in the period of REM sleep when the muscle relaxation has happened. So we do not want to obviously operate the patient for the REM part of the sleep. We want to take care of the 90% part of the sleep. And to my mind, DEX is a very good drug. There are already reports on that. But DEX takes us where we want to reach. It does not take us where we do not want to go.
So yeah, so that discussion again can keep going on. So I think there should be some take-home points. All right. So Hugo has asked a very interesting question. So he says that we need standardization for DICE technique, and after that, we need a universal DICE classification, because in some spaces, in some places, positional DICE is very difficult. And another important thing is duration of DICE. So he just basically given a comment. So I think I'd ask Dr. Maria to comment on that.
Yeah, definitely. I think we need a standardization, but I think it's really, really difficult. I think it's extremely difficult. It's like a big class presentation. I love his system to classify, but sometimes I have difficulty in saying, okay, what palette is this in both? That it's more simple than what he's using. I think that, I don't know, I was in the ISSS in New York in May, and I was hearing Beer talk, and he said, sometimes we don't need a very deep classification. Sometimes we just need something. Actually, in my reports, I always do both, but I also write down what I'm seeing, because I agree with Vikas that it's really important to write a sentence, what is going on. And standardization in the whole planet is going to be really difficult until we don't have more proofs that what is going on, meaning that, okay, the apnea index seems the same with propofol, and it seems the same with midazolam or diazepam in the sleep, normal sleep. But what happens with DEX? There are no studies with this, so we don't know what is going on with DEX. I believe that once the patient starts sleeping and all that, it's all like natural sleep, more or less, if you don't overdose. But we don't really know what is going on. And until we don't have evidence on this, it's going to be really, really difficult. But yes, I do agree that we need it.
So what is your preference in terms of class? Do you use the NOHL, or do you use the vote, or what do you use?
I use the modified vote that is just opening all the labels in the tone base, because tone base sometimes can be lateral, very rare times, and when the lateral walls participate there in the tone base, it's like a circle, like in the CCC in the palate. So I like to do that, just vote, because I think it's the simplest. the simplest one, and we need something that is simple. But classifications are good to do the databases, but it's not good for the patient. For the patient, what I think is true, what I think is good, is what you write down at the end, what your impression. I think the problem is the palate. I think the problem is the tongue. I think the problem is here. That's the good thing. But to compare and to do the database and to know more, we need the classifications.
So I think it's the surgeon's mind. And I think to that end, DICE gives us a beautiful understanding of the behavior of the upper airway.
Yeah.
Because I have one question. Okay,
yeah.
Go ahead, and I have a question for you.
No, if you allow me to share my screen for a moment.
Okay.
See, are you able to see this?
Yes.
This is a software in iPhone where you can just from a distance, if you focus it onto an object, it will measure how big it is. Mm-hmm. So this is software on the iPhone, and this is only the starting. So this is the future. See what will happen in right now. We are all seeing and grading 0, 1 to 50% is all mind. So there is a subjective variation. Now the softwares will come, which will objectively, you put in the scope, the software knows the focal length of your camera and it will objectively measure how much is what. So everything will become objective. Just wait for 5 to 7 years.
Sure. Yeah, I think so. There's a new paper that came out from Australia which shows that basically looking at the facial features, there is a software that is basically going to tell you whether a patient has got OSA or no, just based on facial picture. Anyway, this question, which is pretty long for Vikas, okay. Is from our friend Uttam Agarwal, okay. So, whether you do twice, once with decongestion of the nose and once without. That is the first part of the question. So I would let you answer.
Let me answer. No, Uttam, we do not do DICE twice. That decongestion or without decongestion was only in respect of the nose turbinate. So you look inside the nose without decongestion first, and then you have already given DEX, you are waiting for 5 to 7 minutes. So then you decongest the nose and do the DICE. There's no point doing the DICE without decongestion, because see, you want to know DICE is for dynamic obstruction. It's not for static obstruction. Static obstruction you have to know from CT scan. So you are seeing whether the turbinates are hypertrophied or not. If they're hypertrophied, then when you decongest, then your nose is bypassed, and what is happening into the palate and the base tongue and the epiglottis. That is the role of DICE. So we do DICE only once, but before doing DICE, we put in the scope and see whether the turbinates are hypertrophied or not, and then what is the size of the turbinate after decongestion. Because if the turbinate is more of bone, it will not decongest much. If the turbinate is more of soft tissue, it will decongest too much. Then you know what surgery is to be done on that.
Okay, then the second part of the question is, I think, has been partially discussed in the earlier discussion. Even with new reporting systems, there will be a lot of observer bias, and the whole reporting system will change with different observers reporting differently.
So that's what I just answered. Okay, that objective systems which will come into place, just like I showed you this software, this will eliminate the observer bias in terms of measurements and all. And then obviously you will have, for DEX or propofol, you'll have very, very clear cut pumps which will tell you exactly what is to be given. This will all happen in time.
Third part of the question is, you said that the upper velum does not contribute in collapse. And at what point, the question is, okay, does not contribute in collapse, then what is the point of reporting salpingopharyngeal folds?
No. So in 90% of the patients, upper velum is not responsible. It's not a vertical palate. It's an oblique palate, 90%. 10% is a vertical palate. So even if it is, even then it is going AP. And in 20 to 30% of the patient, the lower part of the upper velum, which is found by the salpingopharyngeal fold, that is contributing to some extent. So therefore, we have reported the salpingopharyngeal fold and its different grades.
Okay, then I think the next question, I think maybe we'll have to, Dr. Maria, do you have any experience on dynamic MRI or DICE, and which is, so I'll ask you and probably Dr. Vijay, because he has some experience in.
Yes, I don't.
You don't. Okay, so the question goes to you, Vijay. Dynamic MRI or DICE, which is more useful for the patient? Pros and cons. That's another lecture. We don't have too much time, but please be very crisp.
Yeah. So both are complementary to each other. So DICE or dynamic MRI is not a diagnosing the patient has OSAS or not. This is a tool to help you to assess where there is an obstruction and what kind of surgery you want to do. So there are pros and cons of dynamic MRI and DICE, which, as Kishore told, we have a separate lecture on it. But dynamic MRIs can also identify the axial views, the pattern of collapse at velum, tongue base, etc., as what we see in DICE, except in certain levels like hypopharyngeal collapse, it will be very difficult. At the same time, DICE can also be difficult to identify whether there is any primary collapse or secondary collapse happening at the level of palate, whether the tongue is really pushing. Though we can do transoral DICE to identify and differentiate the pattern of palatal collapse, it is much easier and clearly visible in a dynamic MRI in a surgical cut. And the soft tissue, the soft tissue reconstruction, airway assessment like dynamic airway assessment can also be calculated with Cine CT, which is recently coming up software with ultra short dose airway reconstruction will help us to identify and help us to compare pre-op and post-op airway changes. So all those, it's imaging in OSA is itself a huge topic which we can discuss. But definitely both are complementary, and some things you may miss in DICE can be picked up in dynamic MRI, and dynamic MRI can also miss some certain findings which will be picked up in DICE.
So just as you say that, the question has come. Would you do dynamic MR and DICE for all your patients?
Yes, expected question, and it is not a first question. So see, dynamic MRI, those patients whom where you can't do DICE, or who are not willing to do DICE, or who are contraindicated, or in obese patients where you want to assess the airway, or who are not CPAP compliant or CPAP not able to use. In those situations, we will be doing a dynamic MRI. At the same time, where my first choice is to do a dynamic MRI, and those who I have a doubt in any, if I'm going to see palatal obstruction, tongue-based obstruction, and whatever the findings which I'm looking at, if I'm going to get it in dynamic MRI, that is much easier and simpler than an interventional DICE.
All right. So I think the next question probably I would ask you, Reena. The question is, does the muscle bulk of the patient decide the suture material that you would use on a palate?
No. I like the barbed suture. I've been using barbed suture since 3 years ago, and I think my results are better. And I'm still trying to figure out how to do the suture, as you could see in the video. This video is quite recent. I did it just like 4 months ago. So trying to figure what the barbed suture is going on. But I use now I'm using quill. I started with the Stratafix. I don't like the V-lock because in my hands the needle turns in the holder and I cannot go exactly where I want. And now I'm using a Stratafix. I was using a Stratafix, and now I prefer quill because it's longer suture with a shorter needle, and I like 26 millimeters. So that's what I'm using. 3 zeros or 2 zeros. I don't know exactly, but that's what I'm using.
All right. So, so the next question I think I'll ask Vikas is that okay. So can prognostic outcomes be included in the reporting system? Patients take reports to irrelevant doctors seeking what to do. So what I think they want to ask is, can you put in some prognostic outcomes in your reporting?
I don't think so. Like if you have a CT scan or a MRI report, CT or MRI report will not discuss into whether the patient is going to
Outcome.
survive or not. No, I don't
Yeah,
think we can include.
absolutely.
See, a prognostic outcome is a totally different thing. We
Correct.
can include all the anatomical factors and basics of the physiological factors. That's it.
So yeah, because the very purpose of this particular investigation is very different.
This is an investigative report. This is not a prognostic report.
All right, and there's another question basically about surgery again. For lymphoid tongue base, which is very big, RF reduction or coblation is better. I mean, who would like to take that?
Simple coblation, no RF in lymphoid tongue base. Lymphoid, how RF will work? It will not. Coblation, you have to remove the lymphoid tissue. For muscular tongue base, you can use RF, you can use cautery, you can use any shrinking technology, but or coblation. But for lymphoid tongue base, you have to remove the tissues, and only removal of tissue as of today is happening by coblation, by volumetric removal. And you can actually, if you want to use either RF or cautery, then you have to cut and hold the whole thing and cut it like a dissection, which is very, very difficult in that area.
Marina, what do you do for lymphoid tongue base?
Coblation.
All right. Do you use the Da Vinci or?
No, we don't have Da Vinci in my hospital. We use just the coblation, the EVAC 70, and that's what we are using.
Yes.
Vijay, are you there? Vijay?
Yeah, I'm there. Yes.
Would you like to take that question also?
Same as because that coblation is the first time.
All right. So I think we have 4 more minutes to spare, and I think we're almost at the end of the discussion. Lots of questions coming on about CPAP and.
So if you pick up some relevant questions, Srinivas,
No,
I think we can extend the time by 10-15 minutes. Mr. Sahaya, is it okay?
Yeah, okay.
All right. I think because we have some time. So again, a lot of questions about, are you satisfied with DICE? Then why to do dynamic MR? So a lot of questions coming in from
We have
there,
already
like
answered. We have already answered.
We've sort of answered that. And then a lot of case scenarios sort of coming up. So which
You
I
pick
don't
up the
think
best
is,
ones. You pick up the best questions, Srinivas.
Yeah, because there are lots. Okay, let me just take one. See, because all of these are explained benefits of CPAP over BiPAP. We have a full
Session
talk
on that.
on the entire session on CPAP and BiPAP and all that. So I think we shouldn't probably talk on that. Probably one thing that I would like to ask Marina is, I think you brought those into your discussion also. So if I were to ask you 5 points that you would look for in your DICE to say that this is a good surgical patient, what would those be?
Wow, that's well. Anytime you have lymphoid hypertrophy, that's a good case for surgery. That for sure. It doesn't matter if it's in the tonsils, palatine tonsils, or tongue base. That's for sure. Every time you are removing lymphoid tissue, that's good. And the rest is just something that you never can tell, because it's really difficult. I think that when you have a primary collapse at the epiglottis is also a very difficult case, because you cut the epiglottis and you think you've solved it, but in some patients, because you remove some area that it creates reflexes, the collapse can even get worse. That's something. It's really difficult, actually. And what I tell my patients is, even though I've studied you, I cannot be sure that I'm going to cure you. And I don't know if you're going to be able to not use CPAP anymore. That's why that's the honest thing to do. But of course, if I see lymphoid tissue hypertrophy, then I say, yes, I'm going to do that. Yes, I'm pretty sure that I'm going to cure you. But even in these cases, there are failures. We know the pathophysiology there. So it's I cannot answer. I'm sorry.
I think
if you allow me to add.
Yeah, just one statement here, Vikas. I think there are some in the meta-analysis that you showed with which Kazarian did. He did speak about anterior posterior collapse being a little favorable, and that's why I think it's a criteria for hypoglossal nerve stimulation.
Yes, but you have to be careful because anteroposterior collapse in the palate sometimes is tricky. If the AP collapse is because of the bone area, you know, this kind of
Correct. The phenotype.
Yeah, the phenotype that Tucker Woodson talk about.
Yes.
If it's very narrow,
Very
the
narrow.
only thing you can have is anteroposterior collapse.
You
so
have a vertical palate.
Yeah, you have, yes, that vertical, I couldn't remember the word, yes. You have to think about that all the time. You always have to keep in mind the bone structure and everything in your mind when you are thinking about one patient.
So the other question, I think, Vikas, you answer this and then I'll go back to Marina.
Yeah, so to answer your question, if I see no allergic rhinitis, no allergy in the nose, a structural problem in the nose, deviated septum, large turbinate, nasopharyngeal like adenoid, because that's the area of the genu where the air has to curve down. If there's obstruction there, if I see any problem in the nose which can be surgically corrected, I'm the happiest person. This is point number one. If I see a oblique palate, if I see a palate which is like a tunnel, sorry, like a funnel, not like a tunnel, I'm very happy because I can do some surgery at the lower end of the palate and I can cure this patient. Like Marina said, lymphoid tissue hypertrophy. These are the things, like 3-4 points. If we see in the dyes, then we know that we can cure this patient or help this patient surgically to a great extent.
Correct. So Marina, the question for you is, do you do any skeletal surgery?
I don't. In my country, it's not allowed for ENTs. It's for maxillofacial surgeons. It's another specialty. Sorry.
So because it's upper airway stimulation is allowed for you, what is the pattern of collapse of the tongue that you would take up for upper airway stimulation?
I think that AP tongue-based collapse is, especially when you see that the muscle is the problem. When you can imagine that is the problem with the muscle, that it's collapsed because of the lack of tone. But in Spain, you can do the hypogloss or nerve stimulation, but only Peter Baptista has experience because it's not allowed in the public system yet. And I only work in public, so I cannot tell you. But
All
that's
right.
what I think.
Is the, yeah, sure. Okay, so the other question, I think towards the end, I think what is the management of OSA with retrognathia, hypoplastic mandible, tongue tie, or a combination of all? How do you go about it?
So I would pick up, see, tongue tie is the best thing to have because then your tongue will not fall.
But
regarding retrognathia, you obviously maxillomandibular advancement, depending on what a skeletal surgery is
correct,
required.
exactly.
We have a separate session on that.
We did have that, and we finished that, I think. So, so the question for Maria, I think specifically is, what success rate do you explain to your patients pre-op?
I don't.
If only you could do that, right?
I don't. I always tell them, actually, it's a good idea to show them the video of dyes. That's why, unless there are big tonsils, I always do dyes before, and then I explain the patient. So I explain the patient, this is where you are obstructing. I think we should do something here, but I don't know what is going to be the result. So I never tell, because you serious are serious, but case serious meaning, but in one patient, if you are success, it's 100% success, and if you fail, it's 100% failure. So I don't.
The other questions again, Vijay, is back to you. Somebody wants to know the difference between PSG and oh, this is Vidyasagar. He wants to know, D. Vidyasagar, differences between PSG and watchpad.
Yeah, and watchpad is, I know you are using it regularly. That picks up the peripheral arterial tone, and it analyzes sleep pattern, respiratory, everything. It is being done with that, and it is widely approved and almost equal, is valuable and sensitive and specific like PSG. PSG is still the gold standard. Simple.
Yeah, I think so. And then probably another thing, Vijay, out of long, I mean, people are really wanting to know more about dynamic MRI. I think we should probably have some session
Yeah, we'll have
yeah.
it, definitely.
Have a
Okay,
talk on dynamic
so
MRI.
on dynamic MRI. So guys, I think we've come to the conclusion of the third webinar on ISSA Classroom. Thank you very, very much, Marina, for coming in, getting up so early and spending your precious time with us. Really appreciate it. I can speak for all of us in IASSA, our heartful thanks to you. At this point, I would like to make a small announcement. See, we have actually advanced our time to 10 o'clock. Also because especially with people coming in, to all our friends coming in from Europe and America to speak to us so that the knowledge percolates through the system. And some of them have to go to work. They want to finish work. They want to finish the webinar and then go to work. And very thankful that they've actually agreed to share their knowledge with us. And that's why I would request all our delegates to sort of log in at 10 a.m. I don't think it's too early for us. If they can get up at 6:30 and give a webinar, I think we should at least come to listen to a talk by them at 10 a.m. at least. That's not too much to ask. And all the other questions that have been asked will be answered by the relevant speakers by email. We have a huge list and we are working on them. And each of these webinars are being uploaded onto YouTube also, so that you all can watch this at a later date. Thank you very much. Again, all the speakers, I would like to ask Mr. Sahai for his vote of thanks, please.
Yeah, thank you, Dr. Srinivas. So before we conclude today's session, just a small announcement to make. Sun Pharma has collaborated with a company called Labrate. As you know, that in medical colleges or the past practice was to see the patient and feel a patient, which probably we never realized that someday, like Corona will come in the world, and we will not be in a position to see the patient physically. So digital team have, there are actually different digital teams in the country who have launched one platform where virtual consultation, teleconsultation is possible. So we have collaborated with the company called Librate, and whosoever is interested can come on this platform. Our colleagues will personally call and will coordinate. For that, we need just 3 documents to enroll the interested doctors to come on that platform. So based on the timings, doctor can log in, patient can log in, and then they can meet each other. Though we have got nothing to do, no personal interest with Librate or with any company which is on using the platform. So just for time being, maybe for next few weeks or few months, till the time many patients are waiting for doctors to see, and many doctors are waiting for patients to see. Till that time, in case you are interested, you can enroll yourself on this platform, Librate. And again, we have no personal interest with the Librate. So absolutely your choice. So before we conclude today's webinar, let me convey my heartiest thanks to Dr. Srinivas, who has beautifully moderated the entire event, Dr. Vijaya Krishnan, Dr. Vidya Sagar, Dr. Vikas Agrawal, and above all, Dr. Naveen Patel. And extremely thankful to our eminent speaker, Dr. Maria Carrasco, who has virtually taken us to a very beautiful journey on a very, very important topic. So thank you to all my delegates, and thank you to the digital team for making the flawless digital program. Thank you. Thanks a lot.
Thank you.
Thank you. Thank you.
Thank you.
Thank you.
Thank you.
Thank you all.
Thank you.
If I may, I would like to compliment you because of this effort of doing these talks, and I think they are being really useful, not only for the Indians, because as you can upload it in YouTube and all that, we can see them and we can all learn for your huge experience. I really enjoy them. Thank you very much for inviting me.
Thank you, as we say it in India. Thank you.
Thank you. Thank you. Vanakkam.